Case number 1, diffuse abnormality, history of abnormal PFTs. Patient was actually relatively asymptomatic. Decide for me what the abnormal lung is and what the normal lung is, and then tell me how you would approach that and differential diagnosis. Episodic fevers and chest pain. Distribution. Density is actually very important here of the abnormality. The density makes a big difference in terms of what diseases we're going to think of. Always look to the fissures when you're thinking of this abnormality and see if you see anything in the fissures or not. Scout view is a radiology classic. I think radiologists like some of these patterns because they have this bizarro differential. We love to torture medical students and residents and fellows. Notice the abnormality is pretty extensive. Another good one, copious cough and copious sputum. This is another sort of radiology classic, but certainly has a differential of a kind of a bunch of bizarro things. What compartment of lung is affected? Alveolar interstitial airways, distribution, differential. Now, when I show board review to my fourth year residents, they always see this case, and they've seen it, usually it's at the very end of the year, and they've seen it so many times, they all yell at in one like fell swoop. Ah, like that. Sorry. Now, this is sort of there's a non-specific finding here, but the patient had a history of recurrent pneumonias when was relatively young. And that history is a bit helpful with this entity on plain film. There's clearly a differential diagnosis on plain film, but what would cause recurrent pneumonias? I mean, clearly this could be an acute pneumonia, but it's not. This is a classic. The question you really should ask in a case like this are the patient's symptoms acute or chronic? Because in fact, the vast majority of patients who look like this will not have the disease that you're all thinking of right now. But if they have chronic symptoms, they likely will. This is a tough one. This is a bit over the level of cases you'll probably see, but notice the difference in lung density between the two sides. Also notice lung volumes, one side compared to another. So differential for unilateral lucent lung. Another good one. Look at the vessels in particular and how this abnormality is affecting the vessels. This is also a challenging case. I don't think that anyone would be shown this. You might be shown this entity, but not necessarily this level of challenge. Radiology classic, my favorite disease. I recently went to Mexico and lectured on this, and I talked about this disease, and they were like, what the hell are you talking about? Supposedly it's very uncommon in Mexico. Very common here. You show like 5 or 6 cases of a disease they see maybe once every 2 years. They're like, ugh. Okay. Distribution of findings. Another radiology classic. This was originally described with one disease, but in fact that disease is very uncommon these days, and so there's definitely a differential diagnosis here. Probably the differential, number 1 in this is actually the same as the last case these days. Nice classic radiology diff. And I think maybe 2 more. Routine. This patient was asymptomatic. So it's a very typical constellation of findings. And then the question is, what is causing it? And what should you do to evaluate it further, if anything? Okay, so first case, heterogeneous lung density, very geographic regions of opaque and lucent lung. Question is, which lung is abnormal, okay? Is the lucent lung abnormal? And if that lucent lung is abnormal, it's mosaic perfusion. Or is the opaque lung abnormal and the pattern is ground glass opacity? 3 ways to differentiate. When there's a very sharp geographic distinction between the lucent and opaque lung, you can draw a line with the difference between the two. Usually the lucent lung is abnormal and the pattern is mosaic perfusion. When there is air trapping and the lucent lung, as the patient breathes out, stays lucent, whereas the opaque lung gets denser, then it's not only mosaic perfusion, but it's mosaic perfusion from small airways disease. Remember, the differential is small airways and small vessel disease, but if you see air trapping, clearly it's small airways disease. Last one is vessel size discrepancy, which you may or may not see. If the vessels are a lot bigger in the opaque lung regions and a lot smaller in the lucent lung regions, then the pattern is mosaic perfusion and the lucent lung is abnormal, okay? Mosaic perfusion, long differential diagnosis. There's actually anything that causes airways disease or vessel disease can cause mosaic perfusion. But most commonly it's small airways disease. If it is the predominant finding though, that's when it's useful to talk about it. You know, you can get it in cystic fibrosis, but in that case, the bronchiectasis is the predominant abnormality. But if it is the predominant abnormality, it's almost always one of these four things. And sometimes you can tell the difference between mosaic perfusion and small airways disease versus vascular disease, all right? This is a nice example of mosaic perfusion from airways disease, where the lucent lung is very lobular. I always tell my residents, it looks like you took a cookie cutter in the shape of a lobule and just popped a couple of those out of the lung, right? See how lobular it looks? That's mosaic perfusion from small airways disease, differential constrictor bronchiolitis or bronchiolitis obliterans, same disease, asthma and hypersensitivity pneumonitis, all right? That was constrictor bronchiolitis. Beautiful example of nodules. Nodules are a very specific distribution. Notice how they spare the pleural surfaces. They look very evenly spaced. Those are both features of central lobular disease. Central lobular disease, you can further break it down, and this makes your differential relatively focused. The nodules can be very indistinct or of ground glass opacity, or they can be very dense, all right? If they are of this pattern, which I just showed you, and this is another case of that, which Rick showed earlier, of ground glass opacity, the differential is predominantly HP. And if the patient has a known exposure, you're done. It's actually diagnostic of that disease. If they are a smoker, respiratory bronchiolitis. Respiratory bronchiolitis, all it is you breathe in smoke, you get inflammation from the smoke around the small airways. That's all it represents, all right? Looks exactly the same. Occasionally, if the patient has just acute symptoms, you can get a viral infection which cause a peribronchiolar inflammation. Follicular bronchiolitis, which we've talked about, is quite rare, and I would never mention it unless I had a history of Sjogren's disease or something, or immunosuppression. And then there are very rare vascular causes. But primarily, we're talking about HP and maybe a couple others. And if you say those three things, you're free and clear. If the nodules are dense, like in this case, all right, totally different appearance, but still central lobular. Notice how they spare the subpleural surfaces and are fairly evenly spaced. When the nodules are dense, most commonly that's endobronchial spread of infection. Not specific with regards to the type of infection, but most likely infection. Remember, aspiration by itself without infection can rarely do this. Remember tumor. And if it's situation, when it's real patchy and heterogeneous like this, that's your differential. If it's very symmetric, then you can consider some of those things, but also remember vascular causes like pulmonary edema and pulmonary hemorrhage and things. So this is a beautiful example of hypersensitivity pneumonitis, okay? Could be if it was a smoker, respiratory bronchiolitis. If the patient just had acute symptoms, viral bronchiolitis. Beautiful example of tracheal wall thickening. You see tracheal wall thickening. If you don't have this and you have just a CT image, the question is, does it involve extensive amount of the trachea or is it a very focal lesion? Certainly very focal lesions can be like post-intubation strictures and tuberculosis and a couple of trauma and things like that. But if it's extensive, it's the Bizarro differential. So here's the Bizarro. We call these the oids, amyloid, sarcoid, and the waganoid. There it is, waganoid. Those are the oids. Those are usually in the same differential. Relapsing polychondritis. A couple other things you can talk about. My residents used to mention Klebsiella rhinoscleromatis, I don't even know how to pronounce it, only because it was on Aunt Minnie about 4 years ago, and now they've totally forgotten about it. So I never mention that in the differential diagnosis. Tracheobronchopathia osteochondroplastica, usually that presents as calcified submucosal nodules, so it won't look like thickening. It'll look like focal nodular regions of calcification. And then there is an association between tracheal wall thickening and inflammatory bowel disease. But you're basically going to be talking about these first four, all right? We're talking about tracheal wall thickening. In this case, notice the prominent sparing of the posterior tracheal membrane. Relapsing polychondritis is a disease that affects cartilage. There's no cartilage in the posterior tracheal membrane of any significance, all right? If you don't see that sparing of the posterior tracheal membrane, then you're thinking mostly about amyloid and sarcoid. Relapsing polychondritis should spare that membrane. This is the case of amyloid with involvement of the posterior tracheal membrane. All right, radiology classic, love this case. And hopefully by now you'll be able to recognize that when you see diffuse lung disease, you have to decide, is it alveolar and it looks like confluent whiteness? Is it interstitial and it looks like lines or nodules? Or is it airways and it looks like round things, depending upon the direction of they're coming, either round things coming at you, so it looks like a circle, which is too big or too thick, or if it's running in sort of this direction, it'll look like a tube, which is too big or too thick, or may even look like totally impacted with mucus. This is a really nice example of airways disease, with you have these round circular structures. Some of them have these little demi-lunes, these little, where you have some mucus layering within them, but it is bad bronchiectasis. Bronchiectasis is a very non-specific finding. There are three types: cylindrical, varicose, and cystic. These are three types of inflammatory bronchiectasis. Cystic bronchiectasis, which is what this is not a very non-specific finding. There's only a small handful of diseases that give you that, because those are all diseases which give you chronic, severe inflammation in the airways. And there's only a handful of diseases which give you such chronic, severe inflammation in the airways. When it's in the lower lobes, most commonly it's post-viral as a child, and this is the sequela of that, and this was what they'll have forever. And the pathology of that is also bronchiolitis obliterans or constrictor bronchiolitis. They have it as a child. That's most common. Other things, primary ciliary dyskinesia, where you have ciliary dysfunction. When the situs is random in those cases, so 50% of patients with primary ciliary dyskinesia will have situs inversus, at which point you can call it Cartagena or Cartaginous or however you pronounce it. Some of the immunodeficiencies, like agammaglobulinemia, again, has in common severe chronic inflammation in the airways. And then there's some of the congenital anomalies of the bronchial and tracheal cartilage themselves, like these things. All right? Love this differential, totally bizarro. Again, chronic airway inflammation. Nice example. This is post-viral bronchiectasis. This person had a severe adenovirus infection as a kid. This is what's left over. If it's in the upper lobes and it's asymmetric or patchy, it's not symmetric, then we're thinking of other diseases. Nice example of a sort of finger and glove appearance. Looks like a tubular opacity radiating out from the hilum, probably a bronchus. So when it's in the upper lobes and it's perfectly symmetric, then we're thinking mainly of cystic fibrosis. But when it's asymmetric, we're thinking predominantly of allergic bronchopulmonary aspergillosis, so you may want to ask if the patient has a history of asthma, tuberculosis, and then these other things are less common to cause really bad bronchiectasis, but things you don't want to miss, particularly endobronchial tumor, and bronchial atresia, which we'll talk about later. That was one of the later cases. Okay, high-density mucus, this is the CT to correspond with that. High-density mucus in an impacted dilated bronchus. Beautiful example of allergic bronchopulmonary aspergillosis. Asks for a history of asthma. Classic, what is this? Left upper lobe collapse. All right, let's say it all in one big thing. Okay, people often misinterpret this as mass in the hilum. Why does it look like a mass in the hilum? Because the hilum's elevated, and that makes it look larger than it should be. But notice that the diaphragm is also elevated, all right? This sort of hazy veil-like density with signs of volume loss. When you get collapse in the left upper lobe, you don't see the fissure. Why? Because the fissure just goes directly anteriorly, because there's not a minor fissure in that case, okay? There is the, what sign's that? There's a lucency, curvilinear lucency, not a great example, around the aorta. The Lufsickle sign. All right, great. There's the fissure of left upper lobe collapse. Again, notice how it goes directly anteriorly, and you're not going to see it on the front of you of the chest. So it just looks like this sort of veil-like density. So it's the other signs of volume loss, which are very helpful. Some very brief things about lobar collapse, which you're probably mostly familiar with. Most important sign, displacement of fissures. You can see other signs of volume loss, which are supportive, particularly in a case like this, but the fissure is the most important sign. Some of the most common causes, mucus plug tumor, number 1 and 2. Then there's some other things like in the lower lobes, aspirated foreign body, extrinsic compression. Sometimes you get these sort of nasty calcified nodes from old fungal disease that compress the bronchus from the outside. And then obviously in the lower lobes, it's a much more non-specific finding because there are all these passive causes of atelectasis. What sign is this? Another radiology classic. There's the fissure. So this is right upper lobe collapse because the fissure is displaced upwards. Notice the contour of the fissure, and there's a big mass sitting here, okay? Because the fissure should not be bulged out there medially. S sign of Golden, right upper lobe collapse, hilar tumor, okay? Left lower lobe collapse, typically you're not going to see the major fissures because they run obliquely to the plane of the X-ray beams. But occasionally you will see it and it gives you this triangular appearance when the volume loss is very severe. Don't forget, I showed this earlier, combined right middle and lower lobe collapse. You have an opacity at the base. The peak of that opacity, at the top of it is medial, all right? This is not an elevated diaphragm. This is not a subpulmonic effusion. This is combined right middle and lower lobe collapse from bronchus intermedius obstruction. Okay, again, history is really important in this case. There's a focal opacity here, recurrent pneumonias. What do we think about with recurrent pneumonias? Well, in a young patient, one of the things we think about is what this is. There it is. Focal, it's just a focal area of consolidation, a little bit rounded. This is a bronchogram. We don't do these anymore, but notice that there's an area of where there's no contrast. So this is something that's sequestered away from the normal bronchial anatomy. Notice here the systemic arterial supply, which is abnormal to the lung, right? And the venous drainage to the systemic veins. So this is an intralobar sequestration. Again, the history was really important there. In terms of intralobar versus extralobar, some very brief points. Obviously, intralobar is within the normal pleural covering of the lung, whereas extralobar is not. Intralobar, the current thinking, this is somewhat debatable, the current thinking is you get you really bad pneumonia, the bronchi actually get occluded to a region of lung, so many people think that the intralobar sequestration is an acquired process, not a congenital process. There's still a debate. Whereas an extralobar sequestration is probably, is almost certainly a congenital abnormality. Intralobar presents in an adult with infection. Extralobar presents usually in an infant or child, and it's an incidental finding because they're getting worked up for some sort of associated congenital heart disease or some other congenital disease. There's systemic arterial supply in both, and on the CT scan, that's one of the most important findings to look for. With intralobar, you can get either systemic or pulmonary venous drainage, whereas in extralobar, you only have systemic drainage, okay? Nice example, sort of this dysmorphic appearing lung with areas of weird consolidation, maybe some areas of lucency out here. Kind of looks dysmorphic. You can see that there are big vessels coming right off of the aorta, supplying that area of lung. And you can see the draining vein to the asgus, hemiasgus system there. And a nice example of an intralobar sequestration. Person has a great history, had a history of prior infection, like 15 years ago, and that's what's left over. Older patient, presents with infection. The density is quite variable with intralobar sequestration. We've seen cases which were completely solid. We've seen cases which were completely lucent or any combination in between. Systemic arterial supply, venous drainage is variable. Here's a nice extralobar. Looks like a mass. Patient had no chest symptoms. They were getting worked up for some cardiac disease. All right, we find this incidental mass. Looks solid, very typical of extralobar sequestration. We see this anomalous blood supply to that solid mass coming off of the aorta. Extralobar sequestration. Again, kids or infants, incidental, workup for other congenital abnormalities is solid, is more consistently solid, unusual to get infection. You have the same systemic arterial supply, almost always have systemic venous drainage. This is right alveolar proteinosis. The pattern is crazy paving, the combination of ground glass opacity and interlobular septal thickening in the same regions of lung. You must ask, are the patient's symptoms acute or chronic? If these symptoms are acute, it's pretty unlikely to be alveolar proteinosis, even though it really looks like it. It's more likely to be basically anything that can cause ground glass, viral infection, edema, hemorrhage, diffuse alveolar damage, any of those things. In the chronic setting, if it's symmetric and geographic like this, it's most likely going to be alveolar proteinosis. So the combination of those two, very nonspecific. The differential diagnosis is nearly the same as ground glass by itself, but really depends upon symptom duration. Now, I think in your handout, I would get rid of those. So the things I've seen which have produced crazy paving in the chronic setting are mainly alveolar proteinosis, lipoid pneumonia. I've seen one case of BAC that was completely misinterpreted for alveolar proteinosis. Patient had a history of alveolar proteinosis, actually was all tumor. But these other things will not produce the prominent crazy paving. So again, in the chronic setting, if it looks symmetric and geographic like this, it's going to mostly be this one. Okay, and that's what it was. Symptoms were chronic. All right, this is a tough case. The reason I put this case up is to discuss the differential diagnosis of a unilateral lucent lung, because that's something that people like to talk about. So I think of this like I start from outside and I work my way in. So outside would be soft tissues. So maybe the patients have mastectomy, maybe they have congenital absence of the pectoralis muscle, like Poland syndrome. Never forget pneumothorax. It's not unreasonable to mention it. Say sometimes you don't see the pleural line. I would consider pneumothorax. If there's a concern for that in chest pain, you may want to get a decubitus view. But most of these are going to be some sort of parenchymal abnormality, and what those all have in common is they typically are bronchial obstruction, and you get air trapping, or abnormal perfusion distal to an endobronchial obstruction. And that obstruction may be from tumor, maybe from stricture, maybe an aspirated foreign body, or it may be atresia where the bronchus is congenitally narrow or congenitally absent. And then particularly if it's small in volume, think of Swyer-James syndrome. And then remember vascular disease, it's uncommon, but if you have a unilateral pulmonary embolism, that will decrease vascularity, called the Westermarck sign. This is Swyer-James syndrome. And the things that point to that to me are the unilateral loosened lung, the fact that that lung is small, right? Usually with endobronchial obstruction, the lung is increased because it's hyperexpanded. And it looks like there actually is some bronchiectasis here. Swyer-James is post-infectious bronchiolitis obliterans, and it just happens to be very asymmetric for whatever reason. And you can see that the pulmonary artery is much smaller on the left side, the lung is loosened, and you have bronchiectasis. Those are really the feature. Unilateral loosened lung, small lung. Occasionally it's normal, rarely it's increased in volume. So if it's increased in volume, it doesn't exclude that diagnosis, and bronchiectasis. Nice example of infiltrative mediastinal soft tissue. So what's our differential diagnosis? Notice the pulmonary vein actually looks very stenotic or occluded in that region. And that's sort of the tip-off to what this is, although I have to say it's a really subtle finding in this case. So we're thinking of some tumors that sort of are infiltrative, like lymphoma, leukemia. Occasionally metastases don't look as mass-like, and they just sort of infiltrate. This happens sometimes. If the patient has acute symptoms only, fever, mediastinitis, or have just chronic symptoms, we would think of fibrosing mediastinitis. And my favorite is Erdheim-Chester. I've actually seen one case de novo of Erdheim-Chester. It's probably the only case I'll see in my entire career. And somehow for boards, that always comes up. I don't know why. Because it seems to be in every differential diagnosis. All right, so this is fibrosing mediastinitis. There are two forms. The diffuse form, which is less common. And typically you see this infiltrative mediastinal soft tissue. It's not associated with granulomatous disease like histo. It's actually associated with autoimmune diseases, so it probably is some sort of autoimmune process. There's another example. We have some infiltrative mediastinal soft tissue. Here's a nice example of some pulmonary arterial narrowing. Everyone see that? And that's usually the tip-off. You have this infiltrative soft tissue, and then the vessels or the bronchi or the veins or the arteries are stenosed or occluded. We can also see some mosaic perfusion because either the vessels or the bronchi are obstructed going to these regions of lung. Fibrosing mediastinus can also be focal. This is more common. There's a nice example, just this sort of isolated, ill-defined prevascular soft tissue that was the only abnormality. This is the majority of cases. The most common locations are paratracheal and subcarinal, often calcified, and this is the one that is associated with particularly old histoplasmosis. We're running through these. Really a radiology classic. Nodules, what's the distribution? You have three choices: random, perilymphatic, centrolobular. Looks real patchy. When it's real patchy like this, it's really unusual for random disease to give you that, because random disease typically is hematogenic spread of infection. Notice there are subpleural nodules present. That essentially excludes centrolobular disease. So what do you have left? Perilymphatic disease. Where are lymphatics in the lung? Around those bronchovascular bundles, in the subpleural region, and within there are lymphatics in the centrolobular region. But as opposed to pure centrolobular disease, there are nodules elsewhere, and the nodules elsewhere tend to predominate. When the nodules are strongly peribronchovascular and subpleural predominant, it's most commonly sarcoid. If the nodules are more in the septa, it's more commonly lymphatic spread of tumor, but it's reasonable to include both of those diseases in the differential of anyone with perilymphatic disease, all right? Some uncommon causes, hopefully you won't see these, but there they are. Here's another nice example of perilymphatic nodules. Peribronchovascular nodules within the peribronchovascular interstitium makes those vessels look beaded. Nodules along those fissures, subpleural nodules. Beautiful example of early sarcoid. In a young, relatively asymptomatic patient, you see this classic distribution of perilymphatic nodules. All of these patients have sarcoid. Lymphadenopathy we talked about already. Usually very symmetric, hilar predominant lymphadenopathy. Also, young, relatively asymptomatic patient. Almost all of those who have perfectly symmetric hilar adenopathy have sarcoid. Remember that sarcoid also can produce fibrosis, which tends to be strongly upper lobe predominant. Okay, another Aunt Minnie of sorts. What's this? Pattern is progressive massive fibrosis. You have these round, masses, symmetric in the upper lobes, a lot of architectural distortion. I call it Aunt Minnie because some people call it the Minnie Mouse sign or the Mickey Mouse sign. You've got the ears above the head, all right? Classically described with silicosis, but that's actually a very rare disease these days. So more commonly when you see this today, it will be sarcoid. But fungal disease like old cocci, old histo can do that. Occasionally talcosis, where you inject oral medications intravenously. But most of these will be sarcoid, okay? Certainly have to mention silicosis, reasonable to mention fungal disease in this differential. This was silicosis. Silicosis can also present with nodules, which tend to be upper lobe predominant, usually posterior. They can also present with calcified nose, again, classically eggshell, but since this is an uncommon disease this day, this is more likely going to be sarcoid, even though this person did have silicosis. Beautiful example, our beautiful classic radiology differential, multiple cavitary nodules. What's your differential going to be? Metastases, infections, particularly septic emboli, fungal disease, mycobacterial disease, and then some of the rarer things. Some other stuff, vasculitis for certain, so be sure to include that. Some other random, rare things, Langerhans, I'll tell you the nodules of Langerhans tend to be quite small, so probably not in this case. Rheumatoid nodules, which are really, really rare. Sometimes we'll see actually tracheobronchial papillomatosis with multiple cavitary nodules. Again, they tend to be smaller. This is someone, notice the cavitary size, or the thickness of the wall. The thickness of the wall in cavitary nodules is somewhat helpful in differentiating malignant from benign disease. So if the wall is less than 5 millimeters, it's likely to be benign. If the wall is in between, it's a toss-up, who knows? And if the wall is greater than 15 millimeters, it's likely to be malignant. This wall's pretty thin. So I would say this is likely to be some sort of benign disease, maybe septic emboli, maybe some sort of fungal disease, mycobacterial disease, septic emboli, I already said that, maybe Wegener's. This patient had Wegener's. Wegener's can present with infarcts, which is probably what the last case represents, or infarcts, or hemorrhage, because it's a vasculitis. This is someone with symmetric perihilar ground glass opacity. Ask the symptom duration. Patient symptoms were acute. Viral infection, hemorrhage, diffuse alveolar damage, pulmonary edema. That's our basic differential. Can't tell them apart, no way to differentiate, give that diff. This is hemorrhage. Wegener's can also present with airways disease. So it's in that differential, right, of tracheal wall thickening. Amyloid, sarcoid, Wegener's, relapsing polychondritis. Those are the big ones. Really a great example of this disease. Notice there is a round thing in the hilum, okay, there, and then there's a focal region of lung lucency. This is actually an impacted bronchus. And in this disease, the impacted bronchus doesn't always appear tubular. Sometimes it can appear like a round mass. The key is, in this region of lung, it's very, very lucent. You see decreased vascularity. So our differential of focal lung lucency is namely bronchial obstruction, and that can be in the lower lobes, typically from aspirated foreign body, but really endobronchial tumor, like lung cancers, like carcinoid would be a classic, bronchial stricture from maybe old TB or something, and bronchial atresia, which is what this disease actually is, and that appearance is sort of classic. Always remember, sequestration can be totally lucent, a little bit uncommon. That's certainly in the differential focal lung lucency, CCAMs, and then some asymmetric bullous disease. But the majority of these cases of focal lung lucency are going to be from bronchial obstruction. This is a pretty classic example of bronchial atresia. Very, very prominent focal lung lucency. Centrally, there is a impacted bronchus, which may be tubular or nodular. This is thought to be a missed congenital lobar emphysema, i.e. the congenital lobar emphysema wasn't severe enough to cause symptoms when the patient was an infant. And so this is just an incidental finding in the majority of patients who are adults. Most commonly in the left upper lobe, second most common right upper lobe, then right middle lobe. Whereas actually sequestration is typically basilar segments of lower lobes. The impacted bronchus may be round or tubular, so if it's round, don't be surprised, and it's usually asymptomatic. By the way, in these cases of suspected bronchial atresia, you should recommend bronchoscopy just to be absolutely sure there's not an endobronchial tumor there like a carcinoid. Last case, this little tubular thing extending down from the lung this direction. I'll give you a hint as to what this is, just for a second. This is scimitar syndrome. There's varying degrees of severity in scimitar syndrome, but the primary abnormalities are partial anomalous pulmonary venous return. This is the anomalous vessel. Systemic arterial supply, the lung is small, and the associated pulmonary artery is small. And there's typically dextral position of the heart, which just means the heart shifted over. It doesn't mean it's situs inversus. Here's another example. This is one of the milder examples I've seen. Partial anomalous pulmonary venous return, heart shifted over, lung looks a little bit small, pulmonary artery I mean, hard to tell here, but it probably is small, okay? Systemic arterial supply, there it is.